Today, I'm going to talk about thoughts and musings on lower gastrointestinal bleeding. I'm James Morris. I'm an assistant professor of medicine in the section of Gastroenterology and Hepatology. And I came to this topic based on the idea that when we see gastrointestinal bleeding, particularly lower gastrointestinal bleeding, most individuals just think that it's lower gastrointestinal bleeding, call the gastroenterologist, and let them take care of the issue. But I'm going to propose to you today that there is a more erudite way of thinking about lower gastrointestinal bleeding, even for the internist, and thinking about the overall holistic approach to the patient and what other medical problems may be going on with the patient. And it's simply more than just let's have GI go and scope the patient. Okay? So I have no conflicts of interest or disclosures, and I will not discuss any unapproved products today, but I will discuss the investigational use of banned ligation for hemostasis, and this is more of a historical probably issue at this point. So the objectives today are the learner will recognize the signs and symptoms of lower GI bleeding and develop strategies for initial management. The learner will acquire skills and determine the etiology of lower GI bleeding to develop treatment strategies, and I'll begin to introduce you to the idea of formulating imaging studies for the diagnosis of lower GI bleeding. So let's talk about a few opening thoughts. When we talk about lower gastrointestinal bleeding, we have an incidence of about 20 to 30% of gastrointestinal bleeding. That means the remaining 80 to 70% of gastrointestinal bleeding comes from an upper GI source or for a small bowel source. Small bowel source meaning that is beyond the duodenum, the second portion of the duodenum, and extending to the terminal ileum. If you look at the incidence of lower gastrointestinal bleeding, what we see is that there is a 200-fold increase from somebody in their second decade of life to their 8th decade of life. And this is a little bit opposite than what we see with upper gastrointestinal bleeding, where an individual may take an NSAID, such as ibuprofen or naproxen, or they have an infection with H. pylori and present with a gastrointestinal bleeding. So the etiology why you may have gastrointestinal bleeding is different from an environmental standpoint. And also we see that as we age, there are potential for comorbidities that may occur that result in a higher risk for gastrointestinal bleeding. And because of that, we see that this increase in the incidence of gastrointestinal bleeding based on age. Now, if you look at the number of patients that a gastroenterologist would see in a year, it's about 10 cases per year. And when I did some self-reflection here, thinking about this is a little bit low probably for what we see at this institution. But in the private setting, that's about what we see as far as number of cases of lower gastrointestinal cases. So they are not as common as what we see for upper GI bleeding. And I thought that was kind of an interesting fact to put it in the perspective. If you take the number of cases per year that are reported to the number of gastroenterologists, it equals out to be about 10 cases per year. If you look at the number of patients that are hospitalized in the U.S. for gastrointestinal bleeding, and particularly for lower gastrointestinal bleeding, it's about 35.7 patients per 100,000 patients are hospitalized. So in thinking about this and reflecting on lower gastrointestinal bleeding, what we see is that the majority of lower gastrointestinal bleeding is self-limited. In fact, 80% of gastrointestinal bleeding will stop on its own. And that's something that as a fellow and as a practitioner now, you always have to keep in the back of your mind that the alarm that you see of gastrointestinal bleeding may not need to be there because most of these will stop on their own. And it's a reassurance that we have. So we also see that these individuals will have a higher hemoglobin as compared to those who have an upper gastrointestinal bleeding. If you look at their need for blood transfusions, it is lower, and they are less likely to have a hypotensive episode. In fact, the mortality rate for lower gastrointestinal bleeding is about 2 to 4%. In the overall gastrointestinal bleeding mortality rate, that rate is about 10%. And if we look at these individuals and we talk about decreasing incidence, this is where we see decreasing incidence in gastrointestinal bleeding. If we look at overall gastrointestinal bleeding mortality, we have not changed that. despite all the endoscopic techniques and things that we've done, really the gastrointestinal bleeding mortality rate still remains about 10%. And if we see that this, if we adjust for sex and age, that's where we see this decreasing incidence. So let me give you a few definitions of lower gastrointestinal bleeding. So bleeding which is distal to the ligament of Treitz was the classic definition for lower gastrointestinal bleeding. A more contemporary definition is that it's a bleeding from a source distal to the ileocecal valve. Remember, I just talked about that small bowel sources of bleeding, and we really are categorizing small bowel sources into a different category because they must be treated in a different manner, okay? And they use different diagnostic techniques, something that's beyond what I'm going to be covering today. There's a way to separate lower gastrointestinal bleeding into acute and to chronic. So acute lower gastrointestinal bleeding is that which is less than 3 days. And these individuals may have hemodynamic instability, they may have significant anemia, or they may have a blood transfusion need. Versus chronic or lower gastrointestinal bleeding, which is several days long, may have an intermittent or slow blood loss. And you categorize chronic lower gastrointestinal bleeding by the signs of fecal occult blood positivity, which has an intermittent melena, maroon or scant bright red blood per rectum. So you can separate the acuity of the patient based on the appearance of the stool output that you see. Now, if we look at the reasons why somebody may have lower gastrointestinal bleeding, we see these in this table here, and we see that the most common reason is diverticular bleeding. It primarily is our major reason for lower gastrointestinal bleeding, followed by angioectasias in second place. There are multiple reasons why one might have a gastrointestinal bleed, and they're listed here, including colorectal neoplasia, inflammatory bowel disease, NSAID-induced colopathies, which result in diaphragms of the colon and subsequently can also lead to edema and lead to bleeding. There's Sterkel ulcers, which are ulcers noted in the rectum that can occur spontaneously in a patient or occur in an individual who has chronic constipation. We also have iatrogenic reasons for an ulcer forming in the rectum, and that includes such things as the Zazi tube, which is a rectal tube that's used in many ICUs. Thankfully, no longer used in our ICUs here because of the risk of significant bleeding that we have found with those type of tubes, and great morbidity with those formation of those ulcers. Dulcifer lesion is also another reason why you may have a reason for lower gastrointestinal bleeding. Remember, this is an end arteriole that bleeds very briskly, but is only about the size of the ballpoint pen tip. So they're very, very small. They're very difficult to find. If you have somebody who has very brisk bleeding and you go down and you can't find a source and you look extensively, you always have to think of this as being a Dulcifer's lesion, and it may require multiple episodes of endoscopy in order to find that very, very small lesion, but they can bleed very briskly. Ischemic colitis is another type of bleeding episode that we can see, and we'll talk about that in a little bit detail. And then we have kind of the miscellaneous category of hemorrhoids and post-polypectomy bleeding, infectious colitis, radiation proctopathy, and rectal varices. So if we look at diverticular bleeding, we see that at 50 years of age, 30% of the population will have colonic diverticula. However, as we increase in age, that incidence of diverticula increases to about 60%. So this has somewhat been described as a normal phenomenon of aging, that we see that most people will get diverticula. There has been debate about whether fiber or high fiber versus low fiber will result in diverticula. The classical teaching has been that if you had a low fiber diet, that would result in a higher incidence and risk of diverticula. But I'm here to tell you that there's some recent evidence that a high fiber diet may actually promote the development of diverticula. So the thinking of how you get to the point of having diverticulosis really needs to be questioned, and we don't have an answer for that for you right now. It is a causative factor for about 20 to 65% of acute lower GI bleeds. And the cause of diverticular bleeding as trauma. Now, when I talk about trauma here, what I'm talking about is the idea that stool or a stool ball or an NSAID irritates the neck of the diverticulum at the vasa recta as they leave the colon. And at that point, if you have friction across that area, that can erode into the vessel and subsequently lead into bleeding. And I'll show you a couple of examples of hemostatic techniques that we'll use to take care of some of these bleeding episodes, and you'll see what I'm talking about there. So having a hard stool when you have diverticulosis has an increased propensity to cause problems. So that's why we want the stool to be soft and bulky in nature, because that reduces the chance of having a complication from the diverticulum. NSAIDs, as all of you know, cause both local mucosal factors, and they also affect prostaglandins. Anytime you have an NSAID on board, there is an increased risk of gastrointestinal bleeding in a patient. And that risk increases with age and other comorbidities. So if you look at the sine qua non of diverticular bleeding, it is a painless bleed. So you do not see individuals come in saying that they have abdominal pain associated with a diverticular bleed. And again, the rule that I was talking about, the 80% resolution of gastrointestinal bleeding, applies here with diverticular bleeding. Most of these patients will resolve their bleeding on their own. It's that 20 to 25% that we have to act on, who are the severe bleeders that are the ones that worry us in the middle of the night. Early rebleeding versus late rebleeding. So the literature is kind of mixed here. So 0 to 38% of patients may have early rebleeding after diverticular bleed, and about 18 to 22% may have late rebleeding after diverticular bleed. And this is probably a result of another diverticular bleeding in that situation, not necessarily the same diverticular bleeding. This is really looking for a needle in a haystack sometimes, because in only 20% of the cases do we find a cause for that diverticular bleeding. So you can imagine that you have 100 potholes in the colon, and you've got to find that spot that's bleeding out of those 100 potholes. That can be very difficult, especially when the field is covered with blood. Finding that one spot that's oozing blood or intermittently bleeding, because these can stop and start spontaneously, is very difficult. When we look at finding the source, oftentimes colonoscopy is better at left-sided. We can see it in about half of the cases. But angiography is usually needed in order to find the source on the right side. And they can find them in about 50 to 95% of cases. If I change the page here and talk about ischemic colitis, we see that the etiology is about 1% to 19% of patients. And we see that it tends to be seen more in elderly patients. Elderly patients because they have a higher risk of cardiovascular complications. They're more likely to have hypertension. They're more likely to have had a stroke. They're more likely to have peripheral vascular disease and cardiovascular disease. So if you look at the symptoms in these, or what happens in these individuals, there is a sudden, often a temporary reduction in the mesenteric blood flow. And so as a result of that, you have hypoperfusion, you may have vasospasm, and you have occlusion of that vessel. As a result of that, you get an ischemic colitis. These tend to be more in watershed areas. So if we see somebody who has a presentation that resembles ischemic colitis, we think of the splenic region and we think of the rectosigmoid region as the most common reasons. However, you have to realize that ischemic colitis can occur anywhere throughout the colon, or it can be extensive throughout the colon. So if you look at the distribution, sigmoid is about 20%, the descending or sigmoid colon about 9%, transverse to the sigmoid colon about 4.2%. The right colon is less, but it's still there. And then in some cases, about 7.3% are pancolonic. Oftentimes, there is an underlying cardiovascular disease process that is present. And the story that I hear when I talk to patients about ischemic colitis is that they are an elderly individual who decided on the hottest day of the year in July to go golfing for 18 rounds at 2 o'clock in the afternoon. And then they don't drink enough fluids, they come back in, and a day or two later they present to the hospital. I've probably heard that story at least a dozen to 2 dozen times of individuals who do not typically stay outside, who decide to go outside under very extreme heat conditions, and this is what sets them up for this problem. So they will present with hypotension or hypovolemia, and when you look at the mechanism, the pathomechanism here, it is a reperfusion injury. And this is one of the examples of a few places where reperfusion may cause an injury to the body. The other example that I think of for reperfusion injury is acalculous cholecystitis, where you have a sudden reperfusion and you have leaky membrane that results in a problem with resulting in colitis. Based on their presentation, it is often a sequential presentation, meaning that they have a sudden onset of crampy abdominal pain, and then they see blood. It is very rare to see blood at the same time that they have bleeding, or to see blood prior to that episode of pain. So this is one of those history points for those of you in the room who are residents. When you're asking the question, when did the bleeding start, and can you correlate it with the abdominal pain that you have? The good resident will be able to tease those history points out. So it's very important that you get that out of the patient. So there is submucosal hemorrhage, and they can have colonic ulcerations. It can be segmental, and oftentimes there is rectal sparing. There's rectal sparing because of this dual blood supply that we see in the rectum that has a preservative effect for this area of the mucosa. One of the signs that you will see on the colonoscopy, and this is probably the best of the images to see it, it's what's called the strip sign on the anti-mesenteric side of the colon. If you see an ulcer that is a few millimeters to a couple of centimeters in width that extends in a line through the colon, and you can see it also here and here, that is a sign that, although not totally pathognomonic, does indicate that this person is at risk for ischemic colitis. Now, when you think of ischemic colitis, if an individual has a severe ischemic colitis or they have right-sided colitis, that individual has a worse prognosis. And that individual also may be at risk for mesenteric ischemia of the small bowel. So as part of the workup, when you identify somebody who has ischemic colitis, say by CT, and there is right-sided involvement, then it should trigger you to begin the process of thinking about, could the small bowel involve, and do I need to evaluate that further with a CT angiography or other technique to help you identify that. Because if that individual has both right-sided ischemic colitis or they have small bowel involvement or both, then they are at a higher risk of mortality. And however, in general, when we talk about ischemic colitis, it's generally a conservative management. For those individuals who don't have that small bowel involvement, it generally is conservative management. So that you can give them fluids, you give them antibiotics in a broad spectrum plan, and most of the time they will resolve on their own. It is still recommended to get a colonoscopy in these individuals to evaluate for the ischemic colitis and the extent of the injury. If I move on to angioectasias, and notice that I did not say AVMs, because an AVM or arteriovenous malformation is a congenital disorder only in the cecum, and it's a large lesion in the cecum. So one of the things that I talk about is residents and students and fellows will come to me and say there's an AVM in the colon, and I just shake my head. And the part of the reason I do that is because the AVM, by definition, is a congenital disorder. And it also happens that my academic great-grandfather is Larry Brandt, who's the person who most advocated that you call them angioectasias versus AVMs. And I never trained under him, but somebody I trained under trained with him, and he was very particular about that. So If you look at lower gastrointestinal bleeding and its incidence, it's about 3% to 15%. We see that if you look at the age distribution for angioectasias, this is really a disease of the elderly, because over 2/3 of the individuals that we identify who have angioectasias are in their 70s or later. And so the reason why this happened is that there are degenerative changes and chronic intermittent low-grade obstructions that occur in these very small vessels and the submucosal vessels that lead to this development of these angioectasias. And these are very small vessels that are having difficulty determining whether they want to be arterial or venous-like. And they often will present on the very surface of the mucosa. If you look at their distribution, they're typically in the right colon, in the cecum and the ascending colon. They can be small, and as I talked about, the AVM is truly a congenital disorder in the cecum. So again, if you look at risk factors for angioectasias, we see that age is probably the most important one. Those individuals who have multiple comorbidities, those with end-stage renal disease are more likely to have angioectasias. If you have one angioectasia, that's probably the only one you have. If you have two angioectasias, you probably have multiple angioectasias. And you can spend hours ablating angioectasias in the colon and not find all the angioectasias. So if you see more than one, there probably are multiple angioectasias. If you are taking an anticoagulant medicine or an antiplatelet drug, you're at a higher risk of bleeding from these angioectasias. And so this may be the source of some individuals who have kind of a chronic blood loss who are on one of these antiplatelet agents. If you can do a trial of holding that antiplatelet agent, you may find that they resolve their bleeding episode. That is not for every patient. That is a case-by-case approach to a patient, but that is something that one can consider. So if you look at this example here, here is an angioectasia at the superior part of the screen right here, a matted tangle of vessels. And they can present as occult bleeding. They can present as melena, because this is typically bleeding coming from the right side of the colon. It does not, it will have that dark appearance. It can also present as hematochezia. And if there are angioectasias, about 80% of them can be found on colonoscopy. I tell you 80% can be found on colonoscopy, but I have to tell you the story of a patient that Dr. Manis and I kind of jointly managed about 7 or 8 years ago, who presented with at least 20 to 25 episodes of gastrointestinal bleeding that we took care of. She had at least 30 or 40 colonoscopies completed here, other hospitals in the city, other tertiary care centers in the region, and world-class hospitals. At the last time that we saw her before she had a colon resection that she was finally convinced had, she had received 247 units of blood for this chronic gastrointestinal bleeding. And the way that one was able to get her to have her colectomy is that one of her friends' relatives was helping to take care of her, and finally went and had coffee with her one day at her home and said, "We're not going to do any more of this, that you reached a point where we can't do any more diagnostic workup anymore. We've got to do something definitive." When she had her right-sided colectomy, the bleeding stopped. So these can be very difficult to find. Now, one of the other things that you see with angioectasias is they can be hidden by Demerol. So this is an example of where a change in practice has occurred in the treatment of patients. 15 years ago, the primary drug that was used for sedation of patients was Demerol. And then began to see this instance of maybe we're missing something with use of Demerol. And so fentanyl was introduced as the drug for sedation for narcotic, and propofol was also introduced at about this time. This was best illustrated for me when I was a fellow at University Hospital on the LSU service in New Orleans, where the policy was that you must use Demerol for colonoscopy, that they did not feel like fentanyl was in their purview that the nurses could use. And we had a lesion that were suspected but could not see it. So we gave naloxone or naltrexone. And within about 2 minutes of giving the naltrexone, a flower bloomed inside the colon. And that flower was an angioectasia that was about 5 or 6 millimeters in diameter. Now, naltrexone is not indicated for that, but I illustrate that story of how much that Demerol can hide a lesion. And I'm going to show that to you here. It does not project well, but if you look right here on the screen, you see kind of a pale blank mucosa. When naloxone was given to a patient, now you see the lesion right here. So this demonstrates that use of Demerol can hide a very small angioectasia or lesion. We don't know the mechanism by which this occurs, but it has been well described, and it shows you that change in thought, and we have to go back and review even your most mundane practices of giving a drug for sedation may have an effect on detecting a lesion. So again, and this is very much like what I saw when we demonstrated that Demerol was hiding a lesion. They bloom out from the center very abruptly once you withdraw the Demerol. Okay. Angioectasias have also been associated with a condition called Heide syndrome. Heide syndrome was first described by Dr. Heide, who was a general practitioner in Washington in 1958, who wrote a letter to the New England Journal and says, I have a group of 10 patients with calcific aortic stenosis who I feel like have been experiencing increased risk of gastrointestinal bleeding. And from that letter to the New England Journal began a series of research that eventually determined that in individuals with severe aortic stenosis, they may develop a type 2 von Willebrand disease. So von Willebrand's factor is a very, very fragile compound. And as you increase the gradient across the vessel, across the valve, what happens, you actually shear the von Willebrand factor. It actually fractures. And you can do studies looking at the von Willebrand factors in these serum of these patients and see that this von Willebrand factor has been sheared across. If you go, I was going to show the animation, but I couldn't get it to work. If you go to the New England Journal and type in Heide syndrome, there is an animation describing von Willebrand's factor and also showing the shear effect, and an animation showing the von Willebrand factor being broken into very small pieces. So in these individuals, that shearing of the von Willebrand factor prevents the platelets from forming when you have a lesion that forms in this colon. Because the platelets cannot work effectively, then you have an increased risk of bleeding and recurrent bleeding. So how do you treat these patients? Well, unfortunately, what you see is you can treat the angioectasia, you can treat the angioectasia, and another one pops up over here, and another one pops up over here, and it's refractory. The actual treatment for this patient is to replace the aortic valve, to do an aortic valve replacement. It's also important to think about this for me, and another point is that this paper describing the shear and the von Willebrand factor was published in the New England Journal in 2003, was the first paper that I read as an intern. And so that paper has always stuck with me after I graduated med school. And so I always, on rounds, everybody has their favorite disease process they have. I remember Dr. Sedetol from pediatrics always liked Pott's puffy tumor. For me, it's been Heide syndrome as that eponym of disease process that you have an affinity to. So, moving on to other reasons why one might bleed are hemorrhoids. And hemorrhoids are a plexus of dilated arteriovenous vessels from both the superior and inferior hemorrhoidal veins. Their presentation as acute GI bleed risk is about 2 to 10%. They are a painless, intermittent, scant hematochezia that coats a stool or drips into the toilet. And that coating the stool or dripping in the toilet, although is not absolutely specific to hemorrhoids, does provide you a historical point to help you in determining the reason for the bleeding. Other reasons why you may have bleeding are colorectal neoplasia. You suspect that with somebody who has a bowel habit changes and weight loss. It's seen in about 17% of individuals who have occult GI bleeding as the reason for their lower gastrointestinal bleed. And oftentimes it's the result of a surface ulceration of the tumor. So the tumor becomes necrotic, it erodes, it becomes irritated, maybe an NSAID gets taken, and subsequently leads to bleeding. If you look at tumor presentation in the colon, we see that on the right side, these tend to be more of an occult type of bleeding, while the left tends to be more of bright red blood or hematochezia. For those who present with a postpolypectomy bleeding, this risk is about 2 to 8% of individuals with acute lower GI bleeding. Its rate is about 8.7 per 1,000 procedures. So it's low, but it's still present. Their presentation can be mild, as in the case of my great uncle who had a postpolypectomy bleed a week ago, versus it can be severe, requiring intervention by the gastroenterologist. And it's something that the gastroenterologist has to be aware of when you do a procedure. If we look at polypectomy and we talk about risk of bleeding after a polypectomy, we can affect early rebleeding. So we can put clips and can do some burning techniques to stop early rebleeding. But late rebleeding, we really have not changed that risk for things that we can do during the colonoscopy. And when we talk about that late rebleeding, you can think of it often like when you cut yourself. So when you cause a cut to your hand or your finger, it bleeds for a little while, and then the platelets come along and coagulation factors and stop the bleeding. And then for the next day or so, it has a tendency to bleed a small amount, but as time progresses, it bleeds less. Okay? Then after about 2 or 3 days, it has a tendency to bleed again, and then there's about a week period of time when you don't see any bleeding, but then you form a scab, and you either pick at the scab or it gets abrased or something, and then it bleeds just a little bit more. That same timeline is what we see in post-polypectomy bleeding. That's about the same timeline that we see. So when we talk about post-polypectomy bleeding, it can be in any time during that time frame, but the risk is lower as we progress out from the polypectomy. If we look at individuals in NSAID usage, we see that there is a higher risk of lower gastrointestinal bleeding as an individual is taking an NSAID. And there is one study that suggests that 86% of individuals who have a lower GI bleed were taking an NSAID at the time that they presented. And these bleeds are a result of local mucosal trauma and inhibition of platelets, and also maybe result from concomitant drugs. And if we look at this graph that's shown here in the bottom right hand of the screen, this is rofecoxib, which is a drug which has been removed from the market. Those of you who have been in medicine for less than 5 years or 10 years will not have experienced this drug, but those of us who are older will remember Vioxx, and it was removed from the market. But it did not cause gastrointestinal bleeding or had a lower risk gastrointestinal bleeding. But if you compare that to naproxen, shown here in the dotted line here, there is a higher cumulative incidence of gastrointestinal bleeding in patients who are taking this drug. And in this cohort of patients, these patients had rheumatoid arthritis. So other reasons one might bleed are shown on this slide, which include rectal ulcers. At 8% will present with a severe hematochezia. Oftentimes this is associated with a lower GI bleed, and we recently had a rectal ulcer present in a patient with end-stage renal disease, respiratory failure. Don't think he had compensated cirrhosis, and there was some risk of malignancy in this patient. So these are the risk factors associated with somebody who has a rectal ulcer. And you can see all degrees of ulcers. You can see clean base, you can see visible vessel, you can see actively bleeding ulcers. And these have a high rebleed rate. The rebleed rate may be as great as 1 in 2 for recurrent rebleeding. If you look at their mortality rate, because of their underlying comorbidities, it is higher than in other gastrointestinal bleeding. And we see that that risk can be as high as half of patients who present with this. Other reasons why you might bleed include radiation proctopathy, which is a condition that occurs after radiation to the pelvis. This is more commonly seen in prostate cancer. We're seeing much less rates of radiation proctopathy than we used to due to better techniques and also monitoring the amount of radiation exposure that a patient may see. But you can also see this in individuals who have cervical cancer or other genital urinary malignancies that receive radiation. So in these individuals, there's a radiation-induced enteritis obliterans that occurs, and then subsequently you have a neovascularization and telangiectasias that form. And I'll show you a picture of that later on in the treatment phase of the talk. IBDs are also a reason why you may have bleeding, and this can present in about 6% of hospitalizations. We have a patient in the hospital currently that has IBD as the reason for their lower gastrointestinal bleeding. AIDS is also a reason in about 2.6% of patients. The reason why these individuals have a risk of bleeding is because of their decrease in their CD4 counts. They have a high mortality. They're more likely to have an HIV-associated thrombocytopenia. They're more likely to have an opportunistic infection. They're more likely to get a parasitic infection or other infection in their colon, and as a result, they have a higher risk of bleeding. If you look at other reasons why persons may be bleeding, it may be an upper source, and that can be seen in 15% of patients for an upper GI bleed, or you may see that a small bowel source is the reason for the bleeding in 15% of patients. So when we talk about treatment for an individual who has lower gastrointestinal bleeding, the primary thing in these individuals is resuscitation. And so for the med school students in the room, this is the slide you should focus on. Resuscitation is the first and most important thing that you should entertain when an individual presents with lower gastrointestinal bleeding. That is the thing that you can act on. That's the thing that you can do before you call a consultant to come in and help you. So remember that if you have melena or hematochezia with advanced age, or they have factors that show that they're hypotensive or tachycardic or overall not doing well, that individual needs a prompt hospitalization. And the first thing you can give them is crystalloids or colloids. If that individual is receiving an anticoagulant drug or an antiplatelet drug, there is a consideration of coagulation factors or platelets should be given. ICU criteria for an individual for lower gastrointestinal bleed is somebody who has comorbidities and requires more than 2 units of blood. You can keep somebody on the floor if they have no comorbidities and they require more than 2 units of blood, but if you have that combination, that's a factor that should probably prompt you to consider ICU admission. The issue of the nasogastric tube comes up. So this is something that is very controversial. Most gastroenterologists do not consider it all that helpful. It should be considered if somebody has hematochezia or they have hemodynamic instability. It doesn't help you rule out a GI bleed. It may help you rule in an upper GI bleed. The good thing about the presence of bile is it's actually a good prognostic sign that you do not have an upper GI bleeding. So when I call and ask if there's an NG tube placed, or if I ask for an NG tube placed, I'm going to be specifically asking, is there bile seen in the tube? Because that helps me to figure out what is my triage here for this patient. So other outcome predictors that we can use for GI bleeding, and these are pretty obvious. If you're tachycardic, if you have a low systolic blood pressure, if that individual has a syncopal episode, if they have a non-tender abdominal exam, that's good. If they have rectal bleeding within 4 hours of their admission, that's not a good sign. If they have use of aspirin or they have a comorbid disease process, those are things that point to an individual who may be at risk of having difficulty or may need closer evaluation. So if we look at lower GI bleed management, we see in this algorithm a strategy for these individuals. So if you have occult bleeding, then an individual should undergo a colonoscopy. If that colonoscopy is negative, then they should proceed with a further workup of upper GI symptoms, including possible EGD. In contrast, if an individual has melena, that is a sign of somebody who has upper GI bleeding, and one should proceed with an upper evaluation with EGD, and then proceed with colonoscopy. In the individual who has scant hematochezia, it's based on alarm symptoms, and it's also based on their age. In these individuals who have scant hematochezia, who are under 40 years of age, you may consider doing a flexible sigmoidoscopy versus a colonoscopy for somebody who's older. I will have to tell you that we probably bypass this issue of the flexible sigmoidoscopy and go to the colonoscopy because oftentimes we find that the prep for flexible sigmoidoscopy is not sufficient, and if it's negative, we're going to proceed with a colonoscopy. So we tend to bypass the flex sig step and go straight to colonoscopy. And now what I want to do is kind of go through some of this workup for these individuals. So if you have occult GI bleeding, this is an individual who has about 10 mils of blood per day, which is lost in their GI tract. That's how you get how much blood you need in order to see occult bleeding. These individuals should undergo a colonoscopy. Alternatively, if you have in your facility CT colonography, it is a consideration. It is not available in this market and probably is not in truthfulness, it's not the best test. It may be considered in somebody who has significant comorbidities. If negative, then you should consider a possible EGD for their evaluation. If the evaluation is negative for the EGD in the colon, then that's when you consider a small bowel evaluation with a capsule endoscopy, a push enteroscopy, a double or single balloon enteroscopy, or a CT enterography, which is a specialized CT scan that can be used with a certain oral contrast that helps you to see the bowel. If we look at Melena, again, we go to EGD as our primary or first step in the evaluation of this patient, realizing that based on the CORI database, which is the Clinical Outcomes Research Initiative, that individuals who have Melena are at also an increased risk of having colorectal cancer. So in those who have no findings on the EGD and are of an age of at risk for being for screening for colon cancer, you should consider doing a colonoscopy. And that odds ratio was 2.87 with the significance level shown here. If the evaluation is negative for the EGD and the colonoscopy, then that's a consideration for a small bowel evaluation. The most common pattern of lower GI bleeding is the intermittent scant hematochezia. And when we see this is usually an anorectal or distal colon source, and that's where we did that endoscopic evaluation that I talked about in the algorithm with regard to choosing flexible sigmoidoscopy or colonoscopy. Now, on this slide, it shows one last category, which is severe hematochezia patients, and these individuals are the ones who need acute aggressive management. So in severe hematochezia, these individuals will need a resuscitation. You need to do orthostatics, obtain lab including CBC, coags, cross-match blood, and consider the nasogastric lavage. And we talked about the nasogastric lavage as if it's positive, then that suggests that there is an upper GI source, and you should proceed with an EGD and proceed with an upper GI treatment algorithm for taking care of that patient. If you have a negative or non-dosttic aspirate, what we're going to consider in that individual is purgatives in order to clean out the bowel to look for the colonoscopy. If that's negative, then we may consider an EGD. And if we find something on that evaluation for colonoscopy for that patient who has severe hematochezia, we're going to treat that. And we're going to talk about that treatment in just a moment. Unfortunately, for some of these patients, they continue to bleed or they present with massive bleeding. In these individuals, surgical consult should be part of your initial order set in order to evaluate that patient. And you consider an angiography or an RBC scan. And I'm going to advocate to you today that in this institution and many others, CT enterography, CT angiography may be the first step in these individuals. So this is a change in practice pattern that we're seeing based on newer data, that we're going to see a movement from the classical tagged RBC scan and angiography to rapid CT angiography to find a potential bleeding site. If you have refractory bleeding in these individuals, this is when you need to call a surgeon to evaluate the patient for possible colectomy or other surgical treatment. And if they do go to angiography and they have embolization, that's a state where we observe the patient. So again, with severe hematochezia, EGD and colonoscopy with hemodynamic instability. Otherwise, you would just consider doing a colonoscopy in these individuals. Your target for the time frame for when that patient presents for the colonoscopy is a target of about 8 hours to 24 hours. So what that means is it's 11 o'clock at night, the patient starts bleeding. Unless they have significant hemodynamic compromise, a colonoscopy at 11:30 at night is not going to help you. You need to get them resuscitated, as we talked about, then consider a purgative, and I'm going to suggest to you that there's a formula for this is to use a polyethylene glycol prep, and you give 1 liter every 30 to 45 minutes. That's faster than what we normally would do, but it has been shown to be safe in these individuals, and you give the polyethylene glycol until it is clear rectal effluent. So that may be 4 liters, that may be 6 liters, okay? You have to weigh it based on what you're seeing with the patient. And then after you've completed the prep, then you target that individual for a colonoscopy within 1 to 2 hours after completion of the prep. So this is a rapid way in order to get the bowel purged so that we can see what's going on in the colon. Without the purge, it is very difficult to find where a lesion may be occurring. When we talk about endoscopic treatments for these individuals, there are several different ways that we can treat these patients. There are thermal contact devices, so we can heat it or electrically burn the tissue. We can clip, placing pressure on a lesion. We can inject epinephrine into the lesion, which causes the vessel to close down. That's generally a temporary treatment. And we can also use other things to look at the lesion, such as cap-assisted. So I'm going to show that to you in a picture in just a moment. And also possibly placing a band. And as I was talking about earlier, this is more of a historical thing than anything. So in cap-assisted eversion, what you see here is an example of a cap that's on the end of a scope. So you can imagine the scope when we have a clear plastic cap on the end of the scope. Just by putting that cap on there, you're able to see in much more detail a lesion and able to target a lesion easier just by the addition of that cap. Once you have that cap in place, as shown here on the picture, you actually suction. So this is a diverticulum that is now everted. Okay? So you have an outie that's now an innie. And once you've got it everted, there you see the vasorector right there in the vessel, and you can put a clip on it. So it's a technique that's been described in the last few years in order to allow you to take care of a diverticulum. By using the cap to suction that mucosa into the cap, it everts the diverticulum and allows you to put a clip there. Here's another way that you can treat a diverticular bleed. This is hemostatic clipping, and what you see on the left side here is a lesion about to be clipped. Here's the clip right here. Turn the light down here. I think it'll make it a little easier to see. Yeah, much better. And in the picture that's shown here in this individual who has some bleeding is the clip about to be applied. And here the clip is placed directly on the vessel inside the diverticulum, right at the neck of the diverticulum. And here's the diverticulum right here. Or, alternatively, you can just close the diverticulum down. So here you see a diverticulum that's bleeding, and this person has zippered the diverticulum closed with a series of hemostatic clips. So you can just close the diverticulum down just by placing these hemostatic clips, and this patient will do well afterwards. This is an example of the band ligation that I was talking about. In this example here, you have a diverticulum here. There's the vessel right here. They apply suction to this diverticulum here. This is the cap on the scope right here, the black with these black rubber bands. And then you see after deployment, there's a black band right here, and here's the lesion right here, and you have caused a local compression of that vessel to keep it from bleeding. So these are all novel ways that people have come up with ways of treating diverticulum. And again, you have to realize that when we do colonoscopy and we're looking for a diverticulum, it is very much looking for a needle in a haystack, and it's very difficult to find that very small lesion in a pool of blood. So this only happens in about 20% of the cases that we scope for diverticular bleeding. So these are not all that common events. I was going to try and show you a video of one that we completed in last year, but unfortunately we couldn't get the video transferred over in time. For angioectasias, their treatment is a little bit different. It is either contact or non-contact thermal coagulation, and sometimes we can put hemostatic clips on these lesions to take care of those. So this is an example of argon plasma coagulation. So if any of you learned how to gas weld metal, then you will understand the principle. It's the exact same principle of a gas welder using argon gas. You electrify this argon gas immediately above a lesion. It creates a plasma, and that plasma will weld down the lesion. This is an example of radiation proctopathy, where you have these telangiectasias, these abnormal growths that have formed as a result of radiation exposure. And after you've activated the plasma, you see these burn sites on the lesion, and eventually you have some resolution of that lesion. This generally requires several sessions in order to ablate these. I couldn't find an angioectasia. It's hard to video argon plasma. I'm going to show a video. It's very hard because it interferes when you try to video it to see that plasma as we do it. Here's another example of an angioectasia. This is a rather large one. You see that it's oozing some blood here, and here you see the borders of it. In this case, what they did is supplemental hemostatic clipping, where they clipped around the lesion. Once they had the lesion clipped at this site, identified by the arrows, then they came back and ablated the lesion, and then came back, ablated the lesion, then they returned several weeks later and looked back at the lesion. You can see the ablation in the center, and the hemostatic clips still in place. These hemostatic clips will generally stay about 6 weeks before they will spontaneously fall off. Occasionally they can be retained in individuals. I typically see the retained clips in individuals with an upper GI lesion versus a lower GI lesion. So there are non-endoscopic treatment techniques that can be used for these individuals with lower gastrointestinal bleeding. And I'll end my discussion with the discussion on these. So mesenteric angiography, we all know, is available. It has to have a risk of renal failure associated with it in those individuals who have renal dysfunction. It is classically the lesion that we use, or the technique that we use to identify individuals who have GI bleeding that we cannot identify a source. It requires a rate of 1 ml per minute in order to see it. Nuclear red blood cell scanning is a technique that is able to detect a bleed of 0.1 mL per minute. It has been used extensively for those GI bleeds that we're not able to find in the colon. And as I talked about, multi-detector row CT scanning is now becoming a possibility and becoming more mainstream with regard to finding a source of bleeding. And surgery is the last resort that we use for lower gastrointestinal bleeding. So if we look at multi-detector CT scanning, what you see here is a lesion right here in the left lower quadrant, and you can see the extravasation of some contrast here identifying that lesion. And the radiologists are becoming very accustomed in order to find these lesions with the CT angiography. The classic tagged red blood cell scan is shown here. As you see in a progression of time in this graph, you see that there is no spot right here, but if you notice, if you follow that, eventually by 45 minutes you see a small extravasation of contrast right here, indicating that there's a right lower quadrant lesion that is bleeding. So that's another way that we can use non-invasive techniques to find a bleeding site. So I'm going to leave you here with this severe hematochezia diagram. Remember that individuals who have severe hematochezia need immediate evaluation with resuscitation, laboratory studies, consideration of the nasogastric tube. Although it cannot rule out an upper GI source, it is helpful potentially for identifying an upper GI source that is leading to a lower GI bleed presentation. Colonoscopy is our primary mechanism in the stable patient or the patient with severe hematochezia in order to find the source of bleeding. I went through the types of techniques that one can use in order to treat these patients. And then for those who have massive bleeding, then we need a surgical consult immediately upon their presentation in case this patient may need surgery for refractory bleeding or severe bleeding. And then we also talked about the non-invasive ways of evaluating these patients, including angiography, CT angiography, and the tagged RBC scan. And those who are successful, it is good for those patients or those who are refractory bleeding. We go back to a potential for surgical evaluation. And so that's my discussion on lower gastrointestinal bleeding, and I'll entertain any questions at this time. Thank you. Sure.
But Angioectasia versus Angioedysplasia.
They're kind of...
Because I know with Angiodysplasias, people can be using angiogenesis inhibitors. Is that something you use?
So I'm glad you brought that up because now I can talk about it. Because it's not, in this case, I was going to discuss it and then I did put it in my disclosure. So there are several people who are using anti-VEGF factors in treating refractory angioctasias. There is also a study in China that was published probably 7 years ago that used thalidomide as a potential treatment for angiodysplasia because thalidomide has anti-VEGF factors associated with it. And in this study in China that I believe had 100 patients in it, the number of blood transfusions that were required to prevent rebleeding was significantly less, or to treat rebleeding was significantly less. Thank you. Anybody else? Thank you.